discuss among the pediatricians about their awareness about these care bundles. When I asked them, almost 80% of them asked care bundle. What do you mean by care bundle? This is what they asked. So I thought, in spite of going into evidence base of care bundles, what evidence base is behind this WAP bundle, CLABSI bundle, and the sepsis prevention bundle? Let me give you a few thoughts about bundle cares in NICU. Basic thoughts. Even a primary care person who is looking after neonates needs to know about this care bundle. Yeah. What is basically care bundle means? It's a set of interventions that, when used together, significantly improve the patient outcomes, because all of us, we need to improve our patient outcomes. For this, we need a multidisciplinary teamwork which has to find out the problem. They need to formulate a plan. They need to work out the plan, and finally, they should enjoy the good, improved outcome. This is what basically care bundle means. Let us make it very simple. By definition, it is a group of evidence-based intervention when executed together resulted in better outcomes. That is, for example, we know the major killer in our premature babies beyond first week is sepsis. So almost we all know hand washing, definitely useful. Yeah, reduces infection. Yes. Next, frequent daily changing of patients' bed sheets. Yes, definitely. Yes. Then, and sterilizing your hands. That is, keeping your hands sterile before and after touching the baby. Even each and every equipment which is in touch with the baby has to be taken care of. All these we know. Appropriate use of antibiotics. All these steps we know. We all know antibiotic has a greater role in treating sepsis. Then hand washing is useful. But when it is done in a haphazard way, we won't succeed. Probably if we have a very high success rate in newborn care, probably we are lacking somewhere. Probably we need to formulate a plan which has to include the major. Already what we have taught, hand washing is the major thing. First, we should take care of it. And in association with the baby, the seats, gadgets, all those stuff which has to be taken care of. All this has to be enlisted, and we should make a plan. We should make it as a guideline. And before that, formulating a guideline, because always what we, most of the policy things which won't work in the field work is the non-involvement of the workers. Basically, if you want to take care of the gadgets and warmers, all those stuff, we need even the healthcare workers. We need to include them in our team along with our major nurses, even the junior most nurse who is going to prepare the fluid. Though fluid or antibiotic will be given by our senior nurse, the preparation will be done by junior nurse. We should include them all, and we need to formulate. We should talk to them in accordance to our own unit maximum what we can give. This is how we need to formulate, and then we need to establish. First and foremost, we should teach about the importance of the problem, and we should include them in the process, and we should get their inputs. We should formulate a plan. In between, if they face itches, as a team leader, we should help them in managing all those steps. And at the end, definitely, if you have followed, because each and individual point has evidence-based, when it is grouped together, that is bundle of care, definitely the outcome should be fruitful. Yeah, this is what. First of all, you need ideas. For example, sepsis, that's what I told. More than 1 week of life, if sepsis is more, yes, you yourself build a care bundle. Steps. First of all, from where the baby is from, labor ward. Okay. There, concentrate from there, receiving the baby and receiving in your ward and all those steps. You build a guideline, educate, then use. This is what? Measure, and then you need to track. You keep on need to track. For example, the sepsis rate may be 30%. It may come down to 10%. If you want to go below 10%, you need to again rephrase, again replan, because all those steps, if it is made as a routine, further reduction, it needs what? Prevention activities like preventing prematurity, all those steps. So in this evidence-based practices, group together using your patient populations, and almost the basic motive behind this bundle care bundle is every healthcare provider has to be involved. We should get inputs before defining a plan. That is what, before defining a plan, because they are the persons who will know. We will be telling them surfactant, even if it comes by 1 o'clock, even if X-ray is not available, if the features are corresponding to RDS, give surfactant. But the thing is, the storekeeper may not be available. So we need to include them. How to keep, at least on an average, about in a month, about 4 babies comes after 12 and before 8 o'clock. So you can keep few vials of surfactant in our local fridge, like that. All those stuff which has to be taken care, and it has to be collectively performed. When there is a hitch, it has to be improvised, and at the end, both these you can achieve: improved patient outcome and reduced healthcare costs. So this multidisciplinary team, which has to be included throughout your bundle care processes, all those attending physician, clinical specialist, leader may be one who may be governing it, but it has to be done. We need to include all this multidisciplinary team to execute their bundle care. See, these are the bundle care, it's already in process. CLABSI, that is CLABSI bundle means CLABSI prevention bundle. Perinatal care bundle to give maximum outcome of a baby. To maximum outcome in the sense both in mortality and morbidity. Even hospital stay we can include. Then BPD bundle, prevention of BPD. Sepsis prevention bundle. Even I thought of leaving some blanks, because you are the person in your unit, you will be knowing what is the major problem in your unit, what is running on. In monthly audit, you may be knowing your own problem. You create your own problem. You create your own bundle. You involve your people. Get it done. That's what. Even this bundles of care, these are proven cares, but you have to individualize for your unit. Okay, let's talk about this CLABSI, that is central line associated bloodstream infection bundle. What they have done? See, they have framed central line initiation bundle and central line maintenance bundle. If we follow these rules, almost we can reduce this CLABSI rates in your unit to a bare minimum, because all these individual cares is having adequate evidence base. See, maximum barrier precautions, hand hygienes, chlorhexidine skin preparation, optimal site selection. More, see, if you don't practice this hand hygiene, definitely you are going to give some infection to the baby. More often they say gram-negative bugs will enter into. Skin preparation, definitely we need to prepare skin. Optimal site selection, if you have selected a site in between the joints, definitely it's going to create trauma and which may act as a nidus for infection. Daily review, just putting a line won't complete this. You need to review the line. This is about the central line insertion bundle. Maintenance, same. Hand hygiene, aseptic technique for accessing and changing needless connections, standardized tubing changes. You need to have your own guidelines. If you have any adverse, for example, putting an intracare, if any appearance of just redness in the tip, sir, this is our unit guideline, we'll take out. It's not that, sir, after 24 hours, we'll change the implant. It won't reduce the infection rate. But giving all those steps, creating a definite guideline may reduce it. Standardized tube changing, daily review of catheter. So even in UK, they say, when I talked to a senior consultant there, he told in 23 weeker, sir, how you are maintaining this CLABSI bundle, how you are giving TPN. He told for TPN alone, they are a separate team. And for TPN nutrition alone, there will be a nurse who will be coming in spite of the routine care being given to the neonate by the neonatal nurses. Just for TPN alone, a sister who is not involved in primary care neonate, because they think even though they wash their hands, they can sterilize their hands, they think they may reside some gram-negative bugs in their hand. So the sister who is not involved in primary care neonatology, she will come, she will be given off for a month, and she will come and she will almost touch those access points, and the ECUs to take care of those knobs. This is what so this is how it was being, almost all the parameters will be included, and it has to be done to reduce the bloodstream infection to the minimum. So bundles tested, this is what I told you: plan, do, study, act, cycles, significant and sustained improvement in reducing CLABSI rate in NICU. Likewise, ventilator, how to prevent ventilator associated pneumonia. We need to train. First of all, first and foremost thing which we are sitting in the era of non-invasive and least invasive ventilation. As much as possible, don't intubate and ventilate, mechanically ventilate. So reducing, for me, if you ask me which is the major strategy to prevent VAP burst, ventilate less possible as possible. So, and even if you are ventilated, each and every hour, count each and every hour or even a minute. If you have an option to take the tube out, act as much as early as possible. The strategies which were followed were healthcare professional training, hand hygiene, airways, suctioning, frequent suctioning. It won't reduce. Some visible secretions you are supposed to do. And avoiding re-intubation, planned intubation, you should have a specific guideline. So oral feeding, oral care. Even in adult studies, they say using chlorhexidine wipes reduces, but in newborns, you use some colostrum to keep the oral cavity sterile. Then positioning about 15 to 30 degrees, they say reflex reduces, and so the VAP may have a marginal improvement. And ventilator circuit, about the ventilator circuit, now CDC says even routinely changing circuits within a week doesn't have any improved statistics in reduction of ventilator associated pneumonia. They say even can be kept for 14 days and until otherwise it is soiled. So this is what we are supposed to do. We need to, researchers acts as a change agent. He used to find out the problem. He used to restain. He need to depromote factor. Few things has to be depromoted. Few things he has to monitor, and he need to analyze the utilization of modified neonatal VAP bundle, and at times he may need to change, unfreeze or refreeze accordingly to get a fruitful outcome. So this is about the perinatal care bundle. The perinatal care bundle to give maximum normal neonate. So antenatal steroids, if at all, if it is less than 34 weeks, vitamin K, infection management, that is more often, if you want to give a best perinatal infant care, just deliver the baby on mother's abdomen. Allow the baby to breastfeed exclusively. Let it be in touch with the mother. That's it. That would be the major perinatal care bundle, but these are the bundle components which they say. But see, by doing that, by practicing that, putting the baby on mother's lap immediately after delivery, and it almost covers everything. Prevents sepsis, gives effective thermal control, it reduces the risk of hypoglycemia, all those stuff. Definitely, it may have a major role in giving a best neonatal outcome. Okay, these are the elements of perinatal care. Partogram, that intrapartum management, social support for labor, unrestricted or upright labor positions, exclusion of unjustified procedures like repeated pervaginal examinations. So prevention of neonatal hypothermia, effective neonatal resuscitation, breastfeeding, all these you can attain if you do a practice. We have a routine practice of putting the baby over mother's lap after surgery. This is BPD prevention bundle. So antenatal steroids, primarily to reduce BPD. Definitely, antenatal steroids may be useful. Delivery room management, that is early CPAP and early and effective technique of administering the surfactant. Use of antibiotics if needed. It's not a routine. If needed, use of systemic and inhaled steroids. Now, the routine use of diuretic or routine closure for PDA in BPD prevention, it doesn't have a bigger evidence. So mode of ventilation, they say volume targeted ventilation has a more role to prevent your BPDs. tidal volume in accordance to the birth weight, and try to avoid lung de-recruitment, in the sense frequent disconnection of tubes. So oxygen, see, in BPD prevention, they say lower oxygen setting, that is 85 to 91, 92 is enough. Medical therapy, antibiotics, you are supposed to give appropriate antibiotics and IV fluids. Routine restriction of fluids is not mandated. You need to individualize upon each and every baby, and optimizing early nutrition and prevention of unplanned extubation. In sepsis prevention bundle, so obtain blood culture prior to administration of antibiotic, administer broad spectrum antibiotic, begin rapid administration of bolus if hypotensive, apply vasopressor and map more than, it's not map 65, it's wrong. Actually, maintain mean arterial pressure in accordance to the gestational age. The same necrotizing enterocolitis bundle, the implementation of the care bundle to reduce the incidence of NEC. Ours unit is a 60-bedded unit where we have around 30 to 40 extreme neonates, that is even less than 1.2 at a single point of time. After this human milk bank, we have started, human milk bank has been started in our unit in the year 2015. After that, this NEC rate has dramatically came down. And if we have a concurrent early onset sepsis or concurrent other reasons for sepsis, then we may land up in NEC. Otherwise, using this breast milk feeding, incidence of NEC is very less. So what they say, in all these elements, you can say, this is what written it is: check, give breast milk, check the tolerance, follow the tolerance. That's it. So I have come to the end almost. Let's start with the story. This is what, when I came by 2014, after finishing my DM from Madras Medical College, ICH, this is what issue was. Sir, almost 60% of premature babies, if the baby receives surfactant, that baby, almost 60%, that baby dies. 2/3 of every baby dies. The baby receives surfactant, it dies. This is what the phrase which was given to me. It was a bigger problem. Sir, major problem in our unit is, if you give surfactant, baby dies, sir. Something is wrong in the surfactant. I thought, how? Surfactant is a definitive treatment of choice for RDS. Why this should happen? Okay, let me rephrase. If at all the baby is dying, it should be severe RDS or extreme preterm with RDS receiving surfactant. That would be the cause for major mortality at times. Okay, right. It is severe RDS or extreme preterm with RDS. Okay, this is the basic problem here. Extreme preterm with RDS and severe RDS is landing up almost in death, 60% mortality. Okay. Collect the data. So I should know the extreme prematurity but severe RDS admission rate, how much I am getting in a month. Then I need to find out why it is happening. So if I want to reduce my unit's mortality, I need to reduce it. So I need to find out the source, how I am getting this. I need to find out the reason. Most often, sir, majority of the prematurity babies, extreme prematurity, mother had concurrent UTI. Okay, this is a major thing. Definitely, it may be useful for my management in the newborn unit, because if the mother's urine has been sent for culture and sensitivity, and if some growth has been documented, sensitive antibiotic which has been documented, that may be definitely useful in preventing early onset sepsis in these extreme preterms, which may be a major killer in those severe RDS babies. So what is the strategies? How much our OG team is motivated towards antenatal steroids, Maxelf, and if at all concurrent chorioamnitis, their antibiotic stand, and how much they are aware of pushing, that is to reduce the prematurity rates, and also how much, if at all, if I am getting from extramural unit, and how much the knowledge is disseminated among the surrounding primary care physicians about in utero transfer, because definitely less than 32 weeker, if at all delivered in a primary healthcare center and then getting shifted and then being given CPAP, surfactant, ventilator, definitely will have a poor rate. That I need to look for. Early CPAP, how much baby has received early CPAP, that is using your TPs or even definitive CPAP from the delivery room. How much baby has received? Then surfactant. How much babies? What is the basic criteria you are using for surfactant replacement therapy? Almost I found out. These are the glitches I found out. Almost, sir, here 1.5 less than 1.5 only we use surfactant. In the sense, okay, more extreme only they are treating. Okay, that may be the reason. If at all 1.8, 1.9, even can get RDS, but there they didn't use. But even they are using more on these extreme preterms. Okay, then storage, about storage, they may be kept. When I found out in the stores, medical stores, they used to keep the surfactant in room air. Okay, this, yes, it may alter, it may be hindering the action of surfactant therapy. Yes, methodology, how we are giving the route, and now we know we are sitting in an era of less invasive surfactant administration. Then immediately after post surfactant, what are the things which has to be monitored? Is there any documentation after giving surfactant? I have noticed just under strict aseptic precautions, 4.5 ml of surfactant given via ET tube. 4 ml you will take from one surfactant 4 ml vial and 0.5 from the another one, and you will keep the remaining 3.5 ml for the next baby. It will be open and kept in the fridge in the NICU. These are the glitches which I found. And regarding post surfactant monitoring care, there was no any definitive monitoring sheet, which is he has to document. If at all he has to document hourly for about 6 hours and every third to fourth hourly, or even he need to motivate his sisters for documentation. Definitive monitoring sheet were not there. These are the glitches. And finally, what was the basic cause of death on those post surfactant baby? Mostly the baby died within 1 or 2 days. So there is a problem in instituting surfactant and immediate post care of the surfactant. So we need to find out and we need to tide over the crisis. So formulate antepartum and intrapartum treatment for any antenatal mothers. Sit along with their OG team. Formulate a plan, antepartum, and if at all, if a mother less than 36 weeks comes, this will be the plan. Will be given tocolytics, will postpone as much as possible. If at all concurrent chorioamnitis, he has to be treated with IV antibiotics. In concurrence, about for past 3 months, what was the growth, which was more common, it has to be selected, it has to be given. Educate and ensure almost not only the consultants, even the CRRIs, OGPGs should be aware about the importance of antenatal steroids, how early, even a single dose may be important. This has to be made aware of. And education, we need to have a policy about the in utero transfer. Definitely government should have a frame a guidelines, because I am sitting in a public sector. You can frame a guidelines, less than 36 weeks, no duty for you to deliver until otherwise the mother has delivered in a precipitate labor. This is what. Then finally, guidelines for early CPAP, guidelines for surfactant therapy, guidelines and monitoring sheet for the babies in the NICU, and anticipate the problem. If at all, if for example, if I found out sepsis was a major care, then what was the organism? What was the sensitivity pattern? Early institution of those sensitive antibiotics, that may be useful. That may be very useful in reducing the outcome, worst outcome. So identify the problem by routine audit, individualize, because you almost your multidisciplinary team should be involved and individualize. You should ask what are the hinders you are facing, why this is not happening. You need to collect the data, educate, motivate, and you need to re-emphasize few things. There may be glitches, you need to re-emphasize, execute the plan, measure the fruitful outcome. If at all, if it is not working, reconsider, something is wrong. If you are getting, but the effect is not that much, probably we need to look for where we are lagging. If we have won it was a very fruitful outcome, then take it as a highly motivating point, motivate your team again, work on something else, because life won't be there, our life won't be, definitely our NICU won't be without any problems. So take home points, know what's wrong, create a bundle plan involving all your teams. If not working, recreate the bundle plan, work again till better outcome. Thank you. Thank you, ma'am. Thank you, on and off.
Thank you, Dr. Senthil, for such an emotional presentation. I think that's part of the work you have done, or things you have gone through. While we take over, we do land in problems, but that should not deter us from uh, finding solutions. I'm very happy that you found solution for one care bundle. But again, I would like to make a comment rather than ask questions to you. Very good work, Sendil.
Yes.
Continue the good work.
Thank you,
And
ma'am.
the second one, see, I would like all the primary care pediatricians